Okay, so my name is Anthony Hobson. I'm a clinical scientist and director of the Functional Gut Clinic. I'm also the chair of the Association of GI Physiologists at the BSG. I've been involved in this kind of research for about 30 years now. As I say, we were very keen on gastric research about 20 years ago, but it seemed to have kind of fallen into a silent period, but things are moving on. And we thought it was time that we should try and update people and generate some discussion and some excitement about some of the technology, diagnostics, and treatments that are becoming available. So I'm going to crack on with the first presentation. Really, this presentation is just an overview of the current situation in terms of how we assess gastric motility, and some of the shortfalls and some of the advances that are coming through. And it's entitled Gastric Motility, Where We Are At. Okay, so first of all, we'll just briefly talk about the gastric emptying process. I mean, by all intents and purposes, it's fairly straightforward. The stomach here is empty and collapsed. And when a meal is consumed, the meal sits in the top part of the fundus. The fundus has to relax and accommodate that meal. And once that accommodation occurs, the meal is slowly fed down into the antrum, which is the motor part of the stomach. And the stomach essentially acts like a pump. So it slowly grinds the food up. And in order to grind effectively, it needs an intact hiatal complex at the top. So you need a good LES barrier so the food doesn't escape as the stomach contracts. And you need a pylorus that contracts and opens to allow that emptying process to occur. So I think this is the first important message, is that the three things that are most important are gastric accommodation, an intact hiatal complex at the top, and a functioning pylorus at the bottom. And then following that, that allows normal gastric motor function and emptying to occur. So gastroparesis is defined as delayed gastric emptying, and this can be caused by many things. It can be related to diabetes. It can be neuropathic in nature, myopathic in nature. It can be due to pyloric outflow obstruction, hiatal defect, as we just touched on in gastroesophageal reflux, but it can also be idiopathic, so no underlying medical conditions, so uncertain origin. It can be due to behavioral measures, so things like rumination and eating disorders. It can be related to the drugs that patients take, such as opioids that slow gastric emptying. It can be nutrition related. So the question is, how do we decipher the causes and what tests are available? So for many years now, gastric emptying scintigraphy using a radio-labeled meal using technetium has been considered the gold standard. Now, this is it's quite a bit of overkill, really, as far as we're concerned, in terms of you need a gamma camera, you need a radio-labeled meal, the subject is in a supine position, but it gives us good quality data. So here you can see the radio-labeled meal in the top part of the stomach, and you can look at how it empties over time. And you can generate these nice decay curves that tell you something about how the gastric emptying is occurring. And they're fairly well-established normal ranges here. So you can look at different time points on the gastric emptying curve, and you can look at the percentage of meal that's left in the stomach. And these are pretty much the normal ranges. So at 4 hours post-meal, there should be about less than 10% of the meal left in the stomach. That's considered normal. You have measures such as T-half, which is the amount of when half of the meal has been emptied, and this is generally less than 90 minutes. And there's very good correlation between this and the 4-hour retention rate. And if you have less than 30% of the meal retained at 60 minutes, this is suggestive of rapid emptying, which is something we don't see particularly common, but is still an important thing to measure. And if people are interested in looking at this in more detail, there's a very good consensus recommendation paper here that was published in 2009, and nothing much has really changed from this point. We tend to use a C13 breath test rather than scintigraphy. And this has several advantages in that it's a much more kind of portable test, so patients can do this at home with supervision. They do it in the upright position, so it's a bit more physiological. And you can use different meals. So we can either use a solid meal, such as an egg sandwich, and you mix the octanoic acid in with the egg yolk, or we can use a semi-solid meal, which is usually porridge. You look at baseline breath samples at the beginning before the patient ingests the substrate, and then they ingest the meal over 2 to 5 minutes. And you can take subsequent breath samples every 15 to 30 minutes for 4 hours. As the meal is digested, the carbon-13 is absorbed into the bloodstream and excreted through the lungs. And the isotope is detected, and this is a non-radioactive isotope, is detected using an IR spectroscopy system. So the results can be fairly instant. And the kind of graphs that we get from this are shown here. And the two measures we look at are T-lag, which is the time to the peak of the response, and T-half, which is the same as scintigraphy, when half of the substrate has been expelled. And there's fairly good and well-established normal ranges here. You can have rapid, normal, delayed, and extremely delayed. So you've done a gastric emptying test. What do you do next? The question is this a behavioral issue? Do you have problems such as rumination? Is it medication related? Should you give a prokinetic drug to speed things up? Can you dilate or Botox the pylorus to encourage outflow from the stomach? Can you perform a hiatus hernia surgical repair to prevent reflux and improve gastric emptying? Should you refer for gastric electrical pacing? And actually, in the States, quite often with severe gastroparesis, they perform quite drastic surgery like gastric bypass. Should you manage these symptoms conservatively and see what happens? The question is, where are we at? How do we make that decision? And really, I think where we are with gastric motility is probably where we were with esophageal motility about 15 years ago. So about 15 years ago, we were doing standard esophageal manometry. We were looking at little waveforms, and we were trying to guess really what these all meant. What does this little pressure rise here mean? Is this related to outflow obstruction? How relevant is the peristaltic picture? What is the functional consequence of this? But over those 15 years, we've moved on to use high resolution manometry. So we've converted to color plots so we can see much more detail and have many more sensors. We've also had the inclusion of impedance, so we can look at the functional consequence of abnormalities. So here you've got a normal swallow with normal clearance. Here you've got a weak swallow and the bolus doesn't clear. So you start to build a picture of function and motility patterns. And what's that allowed us to do? Well, it's allowed us to do things like subclassify conditions like achalasia. So we've got 3 subtypes of achalasia, all require slightly different treatment. This is a type 2 achalasic, and we know that this type of achalasia responds quite well to dilatation and myotomy compared to type 1 and type 3. And there have been outcome studies that have then been done to support that. So this is where we want to head to in terms of gastric motility. So one of the technologies that we've been using for about 10 years now is the wireless motility capsule or smart pill. So this is a capsule that you ingest. It wirelessly sends signals to a data receiver, and that can be downloaded onto a laptop. The recorder has 7 days battery life and the capsule has 16 days life, but most people pass the capsule within a couple of days. So this is the capsule. It looks, I don't know whether you use the model with such small hands actually, but this capsule looks huge. It's about the size of your little fingertip. It's slightly bigger than a pill can. It does take a little bit of swallowing, but generally if people don't have dysphagia or a phobia of swallowing things, it goes down pretty easily. It measures pressure, pH, and temperature. And there's over 150 publications with this technology. And we've got normative data in over 215 healthy volunteers on different days as well. So it's a very well validated technique, even though it's not been widely uptaken. I always like to throw this one in. It always makes me laugh if it doesn't make you laugh, but it's endorsed at the highest level. And this is, I'm just going to show you the stomach data today. So we're not going to concentrate on the small bowel and the colonic data it gets, but this just gives you an idea of what you can pick up in the stomach. So the green here is pH. The red is pressure, so it's looking at contractions, and the blue here is temperature. So the patient swallows the capsule, the temperature goes up to body temperature. They've eaten a meal already, so this is fed gastric motility, and the pH is buffered here during the meal, initial meal period. And as the meal empties and acidifies, it comes back down to fasting levels. And when you're down at fasting levels, you start to pick up migrating motor complex contractions. And this is what empties the capsule through the pylorus into the duodenum, where you get a sudden jump in pH. And then this travels on its merry way down into the duodenum, jejunum, and so on. So this is a fairly normal looking pattern. We've been able to look at the frequency of contractions in the postprandial period and come up with normal ranges, and we have normal ranges for gastric emptying time and so forth. It's been well validated with scintigraphy. So here you see a scintigraphy decay curve, And at the point where the capsule empties, this is equivalent to about 90% emptying on scintigraphy. So there's a good correlation between the two. And you can start to build up different patterns of abnormality. So this is, you can see here that the period where the gastric pH is buffered is prolonged. You've got increased contractions at the beginning here. And then you've got a normal fed pattern as it goes into the duodenum. Here you've got a slightly prolonged post-meal buffering, but it's got a low level of contractility in this early period, so 0.62 contractions per minute. So you've got a what we think is more of a kind of myopathic profile. And you get kind of a neurogenic profile here where you just get erratic contractions during the fed and the fasted period. So we start to begin to subclassify patients on the basis of this. And interestingly here, we've got a patient where they ingested the meal at the beginning. We've got the normal reduction in gastric pH as we would the fed phase, but they never generate a migrating motor complex during this period. So the capsule just doesn't empty. They then take a second meal, so the gastric pH is buffered again. And still, they don't empty the capsule. They don't generate an MMC during the day. But here, the patient's gone to bed. And when just before you wake up, you get a very, very strong migrating motor complex that starts in the stomach and goes all the way down to the colon. And this is normal activity that then pushes the capsule into the duodenum. So it shows that the nerves and the muscles are in place, but actually the signaling might be a problem. And this may be the case in, say, inflammatory or neuroimmune conditions. So we begin to pull together a kind of subclassification based on SMART pill. We can measure things like the buffering of the pH, and this tells us something about gastric acid output. We can look at fed contractility, time to MMC, whether it's slow or rapid emptying or normal, whether there's hypocontractility or hypercontractility. And then we start to build that up with the profile of the patient's phenotype, whether there's a neuroimmune profile, an inflammatory profile, whether we can look at the effects of drugs, look at the spectrum of disease. But it still doesn't really fully explain the neural component, and it still requires multi-center working groups to try and validate these profiles, similar to the way we've done that in the esophagus. So thinking about gastric emptying again, is it reliable? This is a paper that was published quite recently that looked at the reliability of gastric emptying measures over time. And basically the paper showed that if you start off with functional patients with similar symptoms and base that on gastric emptying, you'll have a functional dyspepsia group and a gastroparesis group, but there is an overlap. And 41% of patients that started this process with gastric paresis transitioned to functional dyspepsia, and 37% of people who were classified as functional dyspepsia were reclassified as gastroparesis when they were retested 48 weeks later, despite no change in symptoms. And the interesting thing with this study as well was that gastric emptying time was not associated with symptoms. So this, provoked quite a few editorials of, is gastric emptying dead? Should we not use it anymore? Is it not reliable? So where do we go next? And a technology that's not a new technology, electrogastrography, has had a bit of a reinvention in recent years. And this was a recent study by Ken Koch, who's one of the godfathers of gastric motility measurements. And this looked at the effect of liquid and solid test meals on symptoms, gastromyoelectric activity in patients with both gastroparesis and functional dyspepsia. So the study, there was a 4-hour scintigraphy study to classify patients as either gastroparetic or functional dyspeptics. And there was 284 patients with gastroparesis and 113 with functional dyspepsia. Interestingly, a 90% female rate. Now, all patients underwent a water load satiety test, which is a test of gastric accommodation. And this is where they drink water over 5 minutes until they reach about 7 out of 10 satiety level. And the normal volume is around about 280 mils to be able to ingest during that period. And they recorded EGG at baseline and for 30 minutes following this test. And this was repeated on a second day with a nutrient bar meal. So just looking at the water load test, I think what you can clearly see here is that there's very little difference between those people who had slow gastric emptying and those that had functional dyspepsia. There's a broad spectrum of response from people who tolerate a lot to people who have got poor accommodation, and there's no difference between the two groups. And when you look at the symptoms that were generated either by the cereal bar or by the water load, again, there was no difference between symptoms generated in the two groups. So what about the EGG? So before I go and show you those results, I'll give you some background on EGG, because I say it's an old technique that's had a bit of a reinvention. So the first EGG signals were recorded about 100 years ago. And during the period, it's basically come into fashion and out of fashion a few times. But recently, a company called 3CPM have developed a basic EGG system with quite a clever analysis algorithm. And that's what I'm going to concentrate on here. So what does EGG measure? EGG measures the electrical activity in the stomach, a little bit like the heart. The stomach has a pacemaker region, and this is modulated by ICC cells. And this generates generally a 3 cycles per minute activity. And we can measure this from the surface using electrodes. And what you can see here, this is where the pacemaker region is, and this is where the activity is generated. And this sends signals in this direction to generate the motor function as the meal is being emptied. We can say it's a fairly simple setup. We just have 3 electrodes placed on the abdominal wall. And this is connected to a computer system that filters and makes sure that the signal quality is good that comes through. And as you can see, it's fairly easy. As long as you've not got a really hairy belly, then you can just pop these electrodes on, get a good signal. And the protocol is to do an overnight fast. And then we'll do a baseline recording, just looking at 10 minutes of activity without any stimulus at all. We do the water load test, and then we take 3 10-minute segments of post-water load activity. And this is what the raw signal looks like if you're lucky. You get this nice 3 cycles per minute activity. This is just respiratory activity. And if you get big artifacts that are caused sometimes by people moving or sneezing, you can reduce these and take these out of the analysis and continue and still get good quality signals. But patients need to be reclined at about 45 degrees and told, not to move too much and to keep fairly still. And you can look at the signals in 2 ways. You can look at the spectral analysis. So you can see here a nice spike at 3 cycles per minute. And then that signal increases slightly after water load as the water is being emptied from the stomach. And the graphs that have been produced for normal ranges look at these different frequency lanes. So in the slow frequency range, in the normal frequency range of 3 cycles per minute. And what you can see here is you get normal activity at baseline, and then you get this increase after water. So we've got a fairly good idea of what normal is, but we can also look at tachygastric activity and some duodenal activity as well. What kind of abnormalities can you see? Well, you can see here that you've got fairly normal 3 cycle per minute activity at the beginning, but a kind of mixed spectral response afterwards. You can get the bradygastric. So what this means is that if you have a reduction in 3-CPM activity, this correlates with a reduction in ICC cells, so is indicative of a neuropathic profile. So everything shifts to the left. And you can also get a hyper response where people have a degree of outflow obstruction. And I think this is akin really to what you'd expect with gastroesophageal outflow obstruction, where it's finding it more difficult to push through the pylorus, and therefore the stomach is having to work much harder, and you get an increased response. So if you look at the hypernormal graph here, you can see here that it stays above the normal values at all time points here. And what some of the outcome studies have shown is here you've got hypernormal response and a tight pylorus at this point. And if you do dilatation, then you can bring that back down within the normal range, and the outflow is sorted out, and the water restriction no longer exists. So there are some outcome studies that exist out there, but certainly more are needed going forward. This is my particular interest really, which is around reflux and looking at the EGG and reflux. And this is just a slide looking at post-stretta. So as we touched on before, if you have a weak lower esophageal sphincter or hiatal hernia, as the stomach tries to contract after the water load, the LOS relaxes and you can't generate any pressure, and therefore the pressure just drifts away. And this is just an example of a post-stretta study, which shows after the barrier has been restored to an extent, then the post-water load signal comes back into the normal range. And we're about to do a fairly big clinical trial looking at reflux patients and healthy volunteers in the next couple of months. And again, what this shows is that pre and post, if you've got a look at the EGG spectral analysis, when the hiatal complex is not intact, then you get a fairly chaotic picture. But when you do an intervention, then you can bring that back into order. And also to normalize gastric emptying. So with the 3CPM system, they've reported some outcome studies, again, which need to be repeated in bigger numbers by different groups. But it essentially allows you to look at hypernormal responses, which are akin to outflow obstruction at the pylorus. You can look at GERD predominant symptom profiles, nausea predominant symptom profiles with two. So these people have normal gastric motor activity, but some dysrhythmia after water load. And then you have the hypo-GMA patients who've got evidence of neuropathy, which are much more tricky to deal with. There's not as many options open to them, but certainly gastric pacing and other things can be considered. So what about the EGG from the study that I showed you before? There were no differences between the gastric emptying and symptoms, you might recall. And also when you looked at the gastroparetic and the functional dyspeptic profiles with EGG, there was a range of tachygastric, bradygastric, mixed dysrhythmia, and hyponormal responses. And they were fairly consistent between the groups. And for those people that had normal 3CPM activity, again, you can see there was some hypernormal, so evidence of pyloric outflow, but that was fairly rare in the gastroparetics and the functional dyspeptic patients, only 5 and 9%. So what we're saying here is that with the addition of EGG, you can begin to start to subclassify people on neural abnormalities as opposed to just on gastric emptying status. And if you look at the EGG profiles between the gastroparetics and the functional dyspeptics, again, there's very little differences. So we don't think we can use the gastric emptying really to subclassify patients, as it has no relation to symptoms. But what we think is that these profiles will correlate much better. And I think Greg is going to talk about that in the third talk tonight. So Greg is going to talk about a kind of breakthrough in diagnostic sensing for gastric motility. And that's all I'm going to say about that and how we can make these things more sensitive. So in summary, the symptoms of and gastric emptying measures don't really help identify the etiology and pathophysiology of gastric dysfunction. They also don't help to guide the therapy or predict clinical outcomes, which is, I think, the main reason we're having this conversation tonight. The wireless motility capsule can provide some useful insights into motility patterns and panintestinal issues, but it is quite expensive and also invasive. EGG helps us to identify clinical subtypes within these populations, and I think this extra information can inform decision-making and treatment options. I think outcome studies are definitely needed, and a consensus guideline of how we should be doing this should be developed, and we'll be working on this at a BSG level. I think we're entering a really exciting new phase for foregut physiology that should be translating to considerable patient benefits, and I'm really looking forward to the talks from my colleagues to take this further. So I'm going to stop sharing there and take, if there are any questions. If we don't have any questions at this point, then we can progress on. So Jordan, is there any burning issues?
There's no burning issues, no, Anthony. I have one question though. If you know the study you alluded to, where around 40% patients with gastroparesis and 9 months later will then have a diagnosis of functional dyspepsia and vice versa, and that's based on gastric emptying test being abnormal versus normal. Do you think we should either abandon the test altogether or be offering these patients a repeat test to support or refute a diagnosis of gastroparesis?
Again, if I use esophageal motility as a as a comparator, there were some good studies done by Angelo Angianza back in the past that actually, when you studied a patient for the first time, then quite often you would pick up more abnormalities than you would on the second time. And some of that may be anxiety related, due to the tube and the novelty of the technique, and the control of motility goes beyond just a kind of black and white answer. I think the value of gastric emptying has been questioned, but I still think it's important to get it as a marker. and look at some of the reasons why it might fluctuate over time. So, I think its value has been reduced slightly, but I still think within the package of tests that we're offering, I still think it's important to have that in conjunction with all the other things that we're describing. So we've got a baseline. I mean, we certainly did smart pill studies that showed there was good concurrence over time, and repeat studies. So, maybe it's patient selection that's the issue rather than the test, because these populations are incredibly heterogeneous. But I'm sure that Greg and Noor might have some comments about that. And guys, feel free to step in and have your say on that now.
Sure. Well, if I just put in, we've got a question from Ilyas Sajeev, and he said, what about in patients that present with repeat vomiting? I think we're saying here, a detailed history is probably the best way of choosing which patient should be doing these tests.
Well, as we know one of the issues with doing any gastric motility studies, if the patients have, vomiting and rumination, it's really incredibly difficult to study them. And that's why we try and employ biofeedback techniques to try and at least help reduce the amount that they vomit and regurgitate, so we can actually get some sensible measures of gastric motility. But it does make it incredibly difficult if they have those kind of chronic vomiting issues and can't actually keep the test meal in place. Greg, do you have any points to add to that? Because you must have quite a bit of experience with these kinds of patients.
Yeah, I agree. They're very challenging. Yeah, I agree about gastric emptying. I'm talking a little bit about it as well, and it is at a bit of a crossroads. There's been a lot of criticism, but I do agree it's a useful test, especially when it's positive, to give you some sort of benchmark that there's a problem in the stomach. The bigger problem is what happens when it's negative, and a lot of these patients appear to have the same disease, the same symptoms, epidemiology, quality of life as those who have a delayed gastric emptying, and yet they kind of fall into the cracks, and we don't often know what to do with them. And those are the ones I think who are kind of missing out with a lot of the current diagnostic pathway. And I like the fact that you're looking at alternative physiological measures to try and characterize and subgroup these patients, and that's what I'll be talking a bit more about as well.
Sure. We've got one final question if we've got time, Anthony, before we move on.
Yeah, sure.
So Marianne O'Connor has asked, what effects does mast cell activation syndrome have on gastric motility and gastric emptying? And would gastric emptying tests be useful in these groups, such as Ehlers-Danlos, because they don't often help guide management?
It's quite an interesting study, question, because there's not been any great deal of research on this, but we've had a couple of case studies where patients have had exactly that profile. We did this with smart pill, and the patient, that sticks in my mind that it was almost just like the stomach was in complete stasis, and then all of a sudden something went boom, and then the capsule went through. And we actually repeated that patient when she was on sodium chromoglycate capsules, and her gastric emptying profile normalized. And so it was like really interesting, but n equaled 1. And I know Marianne and Kasim Aziz has looked at these patients and treats them like that, but I think definitely needs some systematic studies with them. But there's definitely something weird going on. And I think the patient I showed where they weren't able to generate a normal MMC kind of during normal post-meal periods, there's something interfering with that signaling pathway that actually is overridden probably by the strong vagal response just before you wake up and you get this big motor complex. So looking between peripheral and central mechanisms is going to be fascinating. And I think the technologies we're going to talk about tonight will help us answer those questions.
Thanks. We're ready to move on.
Okay, great. So I'm delighted to welcome Noor Mohammed, who's a gastroenterologist from Leeds, who's been giving some excellent lectures recently about some of the new clinical interventions, and he's going to talk today about some of the clinical manifestations of gastroparesis and some of the new treatments. So I'm delighted to hand over to Noor.
Thank you, Anthony. Firstly, thank you everyone for joining this hour, and also thank you, Anthony and Jordan, for inviting me to talk about gastroparesis and GPOM. Really interesting talk so far, and I'm looking forward for Greg's talk as well. So let me just, Jordan, could you enable me to screen share, please?
Sorry,
thank
no, you should
Thank
have access to, if you just select all.
Thank you.
S.
Got it.
Yeah.
Got it. Thank you. Oops. Can you see my slides?
Yeah.
Yeah, good. And yeah, now. Good. Okay. So so that's me. I'm one of the consultant gastroenterologists in Leeds Teaching Hospitals, and I'm a interventional endoscopist here. We are going to talk about a bit about gastroparesis. I think Anthony has touched most of the topics about the pathophysiology and stuff. So my talk will be focusing on the GPOM, its details, and the future of GPOM, if we can predict. So without spending much time here, we know about gastroparesis, which is a chronic GI disorder, unfortunately. It's a pretty morbid condition with both significant burden on the patient as well as the healthcare provider, who are trying to achieve some sort of symptom control for our patients. Mainly the symptoms are early satiety, postprandial fullness, nausea, vomiting, and bloating and abdominal discomfort. So predominantly the causes are idiopathic and diabetic, with other causes include post-surgical, and there are various rarer causes, as you've heard from Anthony. One of the biggest studies I've seen recently from one of my colleagues, Professor Ford, is looking at the hospital episode statistics and the research data link. Studied 4.4 million case records and looked at the prevalence of this disease, which turns out to be 13.8 per 100,000 persons, and the incidence is 1.9% per 100,000 person years. The incidence of this in females was 4 times higher due to various reasons, including the hormonal. These are all hypothetical reasons. Nothing has been substantiated in the studies, including the hormonal imbalance between males and females and stuff. So nothing has been found concrete about this. And there is higher incidence in the age group between 60 to 69. This is possibly reflecting on the diagnostic difficulties what we have. If you look at the history in these kind of patients, they have a really long history preceding to their diagnosis. And the pathophysiology, I think Anthony touched upon all these, but it's what we need to understand is the gastroparesis is not a single point disease. It's the pathology is multifocal here. That's what we are understanding about it. Initially, when it was diagnosed, we thought it was abnormal fundal accommodation, which is a problem. And then we realized that there's much more to it, and abnormal antral contraction. There is abnormal pyloric relaxation, i.e. hypertonicity was seen. And more recently, we are also recognizing that antroduodenal reflux is also contributing factor to the pathophysiology. So trying to focus treatment to one point might not be the most successful way of dealing with things. So that's the gist of this slide, if you may. With the available investigations, we've got gastric emptying studies, which again Anthony has spoken widely about, stable isotope breadth test, gastroparesis cardinal symptom index scoring system is one of the scoring systems which is commonly used used in the research settings as well as in the clinical settings. But is it a diagnostic tool? It's no, it is not a diagnostic tool. We'll come to that, the reasons for why it is not a diagnostic tool. And also, more recently, there have been studies to look at the physiology around the pylorus, particularly the manometry and endoflip, and that has come into action. Antroduodenal manometry again to check for the coordination between the stomach, pylorus, and the duodenum. Distensibility index and cross-sectional area of pylorus by endoflip is also being a hot topic in endoscopy world. So this has been explained quite nicely. We've just heard about it. Unfortunately, it is the correlation between the gastric emptying rates as well as the symptoms. It doesn't correlate well. So as a solid diagnostic tool, unfortunately, it fails for us. But as Greg was saying, it is important as a baseline test to have it, and possibly considering repeating depending on when the patient's symptomatology changes, or if there is clinical indications different to what it was. So coming to GCSI, if you look at the symptom subscale, there is nausea, vomiting, fullness and early satiety, and bloating and distension. So apart from the nausea and vomiting, if you look at the rest of the scoring system, the fullness, early satiety, apart from the early satiety and fullness, the rest of the symptoms, if you look at them, they can be present in functional upper GI disorders as well. So this acting as a tool to diagnose condition is unfortunately not the case. And you have, when you have more than 80% of the symptoms correlating with the functional dyspepsia, then unfortunately this is not a very good test. Well, what it does, however, is it's helpful in the post-treatment phase, wherein you assess the patient, you assess the GCSI pre-procedure and post-procedure. So that is the probable way where it should be used as, and not as a diagnostic tool. So EndoFlip is a device marketed by Medtronic and developed by Medtronic, wherein this is a distensible balloon, which is used to assess the real-time distensibility index as well as the cross-sectional area of any sphincter, for example, LOS or pylorus. It assesses the distensibility of the lumen as opposed to the sphincter, and it gives you a color-coded response, a topographic response on the screen, suggesting giving you the distensibility index as well as the pre and post procedural differences in the cross-sectional area. So as you can see on the image, the red on the pre-myotomy side is the sphincter, which is quite tight, and when it is relieved by myotomy, the color changes immediately. This is immediately post-myotomy, and you can get an idea that your myotomy has been a success, and you can predict the clinical outcomes there and then. So it's really good in assessing that, as well as the newer studies that are coming in are to predict the outcomes and to grade the distensibility. We are not there yet to identify what exactly should be the markers for pre and post, but we are getting there, and more research is coming in our way in the coming months and years. So this is something to watch out for in the endoscopy world. Antroduodenal manometry was proposed by Rapici et al.'s group following their randomized control trial, which did not correlate well. The clinical outcomes of G-POEM did not correlate well with any of the categories that they looked into. So they proposed there is much more to it, and antroduodenal manometry should also be, as a research tool, looked at. So one of the groups looked at in a small cohort of patients the outcome of using both end of lip as well as intradiurnal manometry. Unfortunately, it failed to show any predictive abilities of the test to how it can improve the clinical outcomes, or how it can predict the clinical outcomes. So we are limited in medical management, as you know. The symptom control is predominantly the aim of the medical management, as well as prokinetics. And because of the problems with the prokinetics we've had and the restrictions we have in the duration of use, our hands are tied. With the surgical options, gastric pacemaker or pyloromyotomy. These are the two options we have. I'm not going to delve in these because I'm not an expert in talking about gastric pacemaker. Whereas in endoscopic work, there has been recent improvement in terms of the armamentarium, where we can use now a GPOEM, which is gastric per oral endoscopic myotomy. So as well as historic use of botulinum toxin into the pylorus ring. So what exactly is a GPOEM? So technically, this has come after the Notes surgery, wherein you access the extraluminal content by making a tunnel from the mucosa and approaching into the third space. So that's the basis of this. So you identify the pylorus approximately about 5 centimeters away from the pylorus. You inject the submucosa with saline and diluted indigo carmine, and you create a flap, mucosal flap, enter into the submucosal tunnel, reach the pylorus as shown in this image here, and perform a myotomy, i.e. cut the pyloric ring, making sure all of that is all of the pyloric ring is cut in 1 or 2 areas, and then complete the procedure by closing the mucosal flap we have created to enter into the tunnel. And that's the end of the GPOEM. So it's really focused on one thing, and that is pylorospasm. So if you have a pre-myotomy pylorospasm, which is being either diagnosed or you find it when you do the procedure, which is more of a subjective, though, I must say, it is really rewarding because you've directed the treatment where the problem was. But we know that gastroparesis has got multiple other problems involved in association with the pylorospasm. So this is an image on the left-hand side to show the tight pyloric ring, and I'm trying to enter into the pylorus with a conical cap, which is actually much smaller than the endoscope itself. However, that is not allowed because of the spasm you're seeing. So here is the post-myotomy entry, nice and wide open pylorus. So let's look into the procedure itself. So this is an unedited video of the procedure. The time it takes for the procedure is about 60 minutes after anesthetic injection. So firstly, this is the submucosal fluid, which is with an indigo carmine, which is diluted to just give you the differentiation between the submucosa as well as the muscle when we're doing the myotomy. So once we've done that, we then take a knife to make a mucosal incision. So this knife is just about 2 millimeters in length. So we hook into the mucosal surface, use electrocautery, and enter and make space into the submucosa. So the blue, what you're seeing, is the submucosal injection that we've given just. And this is the needle which you're working through slowly. And once we have identified the submucosal space, we then cut the sides, the submucosal area from the sides, from each side, so that the space is wider for us to enter inside. So that's how we are working. So clearing from the sides and moving on, we have now entered into the submucosal space. So this is a fascinating knife wherein you can actually inject the submucosal fluid through the knife itself while you're cutting the submucosal fibers. So again, widening the opening as we are going along and entering into the submucosa, forming a tunnel under the mucosa to reach the pylorus. So that is what we're doing. So slowly working towards the pylorus. That's the intention. So that's lovely submucosal fibers. You will encounter big mucosal, big submucosal vessels, because the duodenal area is supplied by quite big vascular supply. So you have to be careful when you're dissecting. So it's not nice and smooth as we're seeing. So once we've done that and we have gone towards the pylorus, so that's the pyloric ring seen from the submucosa. So the pyloric ring is now being isolated. The superficial, the area which my cursor is, the topmost part of the image, is the duodenal mucosa. You have to be very careful not to puncture the duodenal mucosa. Once you've seen the nice pyloric ring, then the intention is to change the knife to a much more safer knife, which is called as insulated tip knife, and then make that pyloromyotomy. So here is the knife coming. So with an insulated tip, it basically prevents any damage into the duodenal mucosa. If you have a duodenal mucosal damage, then you have a through and through perforation from the stomach into the duodenum, and managing that perforation is going to be quite difficult. So the challenge here is to be very, very, very safe. So here is the insulated tip knife. The white bit of that knife is ceramic, and you pull, it cuts from both the knife itself as well as from under surface of the ceramic ball. So that's how you cut the pylorus. So as I've told you, this is an unedited video, and the myotomy itself takes about 1 minute. So stopping and performing the myotomy slowly and carefully, digging the tip of the knife as close to the pyloric ring from behind as possible, pulling towards us, and making sure we've got a full myotomy, full thickness of pyloric myotomy, as well as 1 centimeter or so of gastric mucosa, as a gastric myotomy as well. So that's, once we've finished the myotomy, then the job is for a safe closure of the mucosal flap. I'm going to skip this video now. This is how you do the closure with clips approximating the mucosal flaps. So there are various ways of closing this mucosal defect, and I'm going to leave that video now. And so there are a couple of new things that are coming into the GPOM category, and that is, instead of a single cut myotomy of the pylorus, we're now using dual cut. This is again an experimental phase, just to make sure that the pyloric ring is cut from 2 different ends, as well as the middle bit of that pylorus is now removed by cold snare technique, leaving a much wider defect of the pylorus. That means there is no chance of those muscle fibers coming back to form a fiber, a ring later on. It's unheard of that even with a single cut it happens, but this is to be absolutely sure and making sure that there is wider gap. But as I said to you, this is in research setting still. We need to know, jury's out about what happens with those compared to the single cut. There are different closure techniques. You can use multiple clips, as on the image on the left-hand side. In the middle, you've got a padlock clip that is a single big clip that can close up to about 2 to 2.5 centimeter mucosal defect. And on the other side, you have endoscopic suturing device that is that use nylon sutures to suture the mucosal defect. There are, again, clinical trials ongoing, so we don't know which one is better, but I have predominantly resorted to using endoscopic suturing for these kind of cases because it gives a visual confirmation that it is all completely closed, as well as avoid any wound dehiscence in the post-op period. So technical success, it's a very, very safe procedure. It is much safer than laparoscopic pyloromyotomy. And there are minor procedure-related adverse events, such as capnoperitoneum, leaking of CO2 into the peritoneum, thermal mucosal injury, i.e. perforation of the duodenum. And cumulatively, this is about 4 to 6%, whereas the laparoscopic pyloromyotomy, the range of the complications are reported have all been more than 10%. So technical success is almost all in all studies. There's been around 100% technical success. As you have seen, the procedure itself is nice and simple and a short procedure. Whereas clinical success, unfortunately, has been reported somewhere around 56 to 82%. There are two systematic reviews and meta-analysis which suggested about 82 to 84% success rate, but a couple of recent studies have actually dampened the enthusiasm on the GPOM. More recently, the one multi-center trial conducted by Muin Kashab's group in John Hopkins have reported 56% success rate, which is just slightly worrying. Having said that, the jury is still out, and I don't think it can be shelved yet, because even if you look at 56%, those 56% have got the treatment in 12 to 24 hours, 24 months time. They still were benefited from the procedure. So considering the comorbidities that gastroparesis brings, 56%, even 56% success rate is pretty good. So, so more research studies are awaited. So from the research, what we have, the predictors of success are predominantly the retention, gastric retention, which is more than 20% at 4 hours, as well as the baseline GCSI, more than 2.6% for fullness and early satiety. And also clinical success at 1 month also predicts the clinical success at 12 months. So these are the reported outcomes. The pitfalls, unfortunately, we have to be very, very careful about this because there is considerable overlap between the gastroparesis and functional dyspepsia. And as you've just heard, it can be diagnosed either way. Functional dyspepsia being diagnosed as gastroparesis is not uncommon. Patients may not always have symptoms of pylorospasm, so try and tease out those symptoms when you're taking the history. It is not easy to combine. And weight loss is not a cardinal symptom in GCSI. In my opinion, it should be, but when present, weight loss is really, really important, and it ushers towards the urgency of the situation. There's no reliable predicting score to identify the right patient for the GPOM, and we have to be careful about over-diagnosing, over-interpretation of the investigations, and over-promising the outcomes to our patients. We have to be really careful to tease out gastroparesis from gastroparesis-like syndrome and chronic unexplained nausea and vomiting. So in conclusion, gastroparesis is common disease with a multi-point, is a complex disease with multi-point pathology, and individualized treatment strategies are required. GPOM is safe, minimally invasive approach for gastroparesis, and just with a couple of studies, I don't think it is ready to shelve yet. And in fact, I would think the other way around, with more data coming on subcategories of the patient groups in which GPOM could be selectively used is important and will shed more lights. In almost all of these studies, which I have quoted, these are all comers with any subcategory of gastroparesis. There is only one study that I could take out from this from my investigation into the subcategories. It is in the post-surgical group, a Chinese study which has shown GPOM to be as successful as about 79%. But what they have suggested is the minimal amount of muscular damage that the stomach receives when you're operating on the esophagus or the stomach, it is better in terms of outcomes, i.e. higher esophagectomy will have better outcomes compared to the partial gastrectomy. So those are the outcomes we have so far. But other subcategories, unfortunately, we do not have much studies to report to. And in my opinion, this is just solely my opinion, that combination of treatment may help in patients who do have multiple complex symptoms and not just pylorospasm. For example, using electric stimulator along with GPOM might help both the propagation of the food as well as the pylorus being wide open. That should help. In the patient selection is paramount, I think, in my opinion, for a successful outcome from GPOM, and reliable predicting scores are needed. So we should not, until then, use GPOM as golden hammer. So I will leave you with this slide, and I conclude my talk. And once again, thank you very much for listening.
Thanks so much, Noel. Jordan, do we have some questions?
Yes, we've got one question from Natalie Page. She says, with EndoFlip, is poor compliance of the pylorus a predictor of clinical success of GPOM?
Say it again, sorry.
So with EndoFlip,
Yep.
is poor compliance of the pylorus or pylorospasms a predictor of clinical success with GPOM?
That's right. Yes, that's right. With what we're measuring here in EndoFlip is the circumferential area of pylorus, and also it gives you the distensibility. If there is no distensibility, that means there is huge amount of pylorospasm. So that's what we are looking at. Although the surface area assessment of surface area of pylorus hasn't resulted in any meaningful clinical outcomes, but whereas the distensibility index is the one which will be keen at looking at in terms of the outcomes, and also that does improve immediately after the GPOM. So if you've done a pyloromyotomy and the distensibility index changes from one to other vastly, but what we are struggling is to grade those into different categories. So that side of research is still ongoing.
Sure. Sorry, I just got one quick question. It's just about Botox. So whilst we don't have a test that predicts response, I feel like clinicians are more inclined to do a trial of Botox just to see if the patient responds to that. But I'm under the impression that Botox can increase the risk of scarring and fibrosis, and could that ultimately reduce the efficacy of GPOM?
You're absolutely right. The first part, you're absolutely right. It causes scarring and fibrosis. In my opinion, plus the experience we've got, it depends on how enthusiastic the injection has been. And if you actually hit the submucosa, and if you've injected in the submucosa, it creates intense scarring as well as pockets of submucosa when you go into the submucosal areas. What it also does is it makes the procedure unsafe. So it's difficult to differentiate between the scarred submucosa and the muscle. So when you're doing the submucosal dissection, it's not safe, and you can damage the mucosa superficial and cause thermal damage, and that can lead to delayed perforation.
That's great. No, thanks for a fantastic talk, and we look forward to seeing more data as it comes through.
Thank you.
Our final speaker tonight is probably about 6:37 a.m. in the morning there in New Zealand. He's joining us from New Zealand now. A truly international session that we've got. Professor Greg O'Grady is a professor of surgery from Auckland, and he's going to tell us about some of the new technologies that are going to hopefully help guide patient selection in a way that will make all of this much more successful and safer for patients.
Thanks, Anthony. I'll just get you to enable screen sharing. But it's great to be here. I've really enjoyed the webinar so far, and thanks for inviting me. Excellent talk on GPOEM. Try and share my screen now. Still disabled.
Should be okay now. Yep.
Great. So hopefully you can see this okay. So I'm going to talk a little bit about gastric motility and where we're heading to. I have some disclosures in that I have some grants and patents, and I'm a founder and CEO of a company called Limetry that we spun out of our research group that I'll be talking a little bit about today. So as the other speakers have talked about, I think gastroparesis is currently in a little bit of maybe an existential crisis. And the reason I say that is because we, obviously we name this disease and define it by delayed gastric emptying, but there's a lot of skepticism about whether this is actually at the heart or the unifying mechanism of this disease. It doesn't correlate with symptoms, and it seems to be variable over time. So it's currently a bit uncertain about how to define this disorder. I've got to say, sometimes when I order this test, I feel a little bit like the drunk guy under the street lamp who's searching for his car keys, and the policeman comes along and tries to help him, and they can't find the car keys. And the policeman says, where did you leave them? And he says, I lost them in the park. And the policeman says, well, why are you looking under the street lamp? And the drunk guy says, well, this is where the light is. And it's a little bit like that with gastric emptying, because, we have this test and we do it all the time, but actually for a lot of patients, it might not be the pathology that we're actually looking for. And that's the way it feels a little bit of the time with this gastric emptying test that defines this disease. We have these symptoms. These are kind of the usual suspects. And as the other speakers have already said, the other problem with defining these disorders based on symptoms is that these symptom disorders overlap. So in our studies, about 80 to 90% of patients with gastroparesis also meet criteria for functional dyspepsia. And there's this other group of patients called chronic nausea and vomiting, or chronic unexplained nausea and vomiting, who seem to have the same disease as gastroparesis a lot of the time, but have normal gastric emptying. So it's really quite confusing. And that, of course, was kind of brought to a head, as Anthony's already talked about, this paper last year. It's got a lot of press about how gastroparesis and functional dyspepsia really seem to overlap, and gastric emptying seems to lack reproducibility. But as we've said, it definitely has a role. It's a baseline test. The authors here said it reinforces the concept that gastric emptying studies are of limited utility. But I think the panelists today agree that it has a baseline function of defining a degree of pathology in these patients. What I think about these disorders is that gastroparesis kind of remains a type 3 problem. And what do I mean by this? Well, there's three types of problems in the world. A type 1 problem is when we know what the problem is and we know what the solution is, like this broken bone. A type 2 problem is when we know what the problem is, but we don't really know the solution, like this metastatic liver disease. But a type 3 problem is when we still don't really know what the problem is and we don't know what the solution is. And I'd still put gastroparesis in this camp. And the history of medicine has, of course, been trying to turn type 3 problems into type 1 problems. And they're very satisfying to treat, and they, patients love them, and all patients think they have a type 1 problem. They'll come to you thinking that you're going to sort this out. But gastroparesis, unfortunately, is still not quite in that category. And so that's just the way we have to understand it as clinicians, that we're on a journey to define this. But I'm hopeful that this will become a type 1 problem as we really bring new tests to light and really understand the pathology of these patients and move beyond symptoms and beyond gastric emptying. The panelists have talked about some other secondary tests of gastric function that are out there, and I won't repeat what they've said. I think, this is really encouraging that there's a lot of work going on in this area, and we hope that a combination of approaches will allow us to really pull out subgroups of patients with specific pathologies that might guide treatment. So just to summarize, the current situation really is that we've got these overlapping phenotypes. We've got some helpful tests, but they're really not specific. And a lot of the time they don't clearly guide management. And that leads to a lot of trial and error therapy. So we don't know who's going to benefit from the GPOM and who's going to benefit from the prokinetics and who isn't. So unfortunately, we're kind of stuck in these trial and error loops. The future has to be building up our data set of actionable biomarkers based on physiological testing that will then lead to personalized and targeted therapy. And this is what our lab has been working on for a long time, to try and deliver perhaps some better actionable biomarkers for gastroparesis in a way that we can help to improve care. As has also been said tonight, this is quite a complex disease, making this difficult thing to do. There's a lot of contributing mechanisms, but I'm going to concentrate today mainly on the dysmotility aspect and how we can at least define the subgroup of patients with abnormal motility who would benefit from some of these pharmacological and invasive therapies, as opposed to those patients with altered central processing gut-brain disorders who probably wouldn't benefit from some of these more invasive therapies. So how do we do that? Well, what we've been looking at is the bulk of gastric motility in this large gastric pump, these muscles, and that control the gastric emptying. And there's a lot more to the stomach function than just transit, than things moving from A to B. And we really need a good way to measure the function of the stomach itself, which we don't have a widely available test for at the moment. We know that underlying these contractions, just as Anthony said, is an electrical rhythm, just like in the heart. And people have tried for a long time to relate this electrical rhythm to diseases, as Anthony talked about with the EGG test. There are a few problems with that test that make it difficult to use in some circumstances, and it hasn't been adopted clinically widely for this reason, although it is still used and finds some useful role in some patients. And the main problems with it is that it has a very low resolution. It's sensitive to noise. The electrodes can miss the stomach. You have to kind of get a strong signal with it, and if they're off the stomach, because the stomach is highly variable in its anatomy, then sometimes you can get a really weak signal. And it can't track wave patterns that are important to the disease, as I'll show you. So we set about trying to develop a better test, and we started with this idea of bringing across cardiac technologies to the stomach and using multi-electrode mapping, which the cardiologists have been doing for a long time in the heart. And we started doing these invasive maps. We built these electrodes to map the patterns and showed what the normal wave function of the stomach is like, as shown here. And then we looked at patients with gastroparesis, and we found some really interesting things. Their patterns were different than those controls, and often they were doing things that were highly abnormal. The waves could be going backwards, for example, as shown here, retrograde waves, or sometimes, as shown in this patient with diabetic gastroparesis, actually this one, they can be highly irregular. So these waves start normal, and then you'll see them become very disorganized and chaotic, all over the place and colliding, kind of a fibrillating type pattern. And so we were able to map these patterns in the stomach of gastroparesis patients using these highly invasive tools. We also measured biopsies of the patients while we were doing it, taking full thickness biopsies from their stomachs. And we found that the patients with these abnormalities had neuromuscular disorders in their stomachs. And we found that even patients with normal gastric emptying, but similar symptoms, had reductions in these cells, particularly the interstitial cells of Cajal that deliver these electrical impulses. So we think there's a spectrum of disease where perhaps in chronic unexplained nausea and vomiting, where the gastric emptying is normal, there's a loss of some cells which becomes more severe in those with delayed gastric emptying. But this again doesn't explain the full spectrum of gastroparesis, just a subset. And these tests were way too invasive for doing in the clinic or in hospital settings. So what we've done since then is tried to develop a non-invasive way to measure these gastric electrical rhythms accurately and reliably in high resolution. Like Anthony said, trying to move the field from what it was 15 years ago in the esophagus with low resolution approaches to these much more robust and reliable high resolution maps that give you more specific diagnostic criteria. So we started with these wearables that we were 3D printing with electrodes, and they gave us some really interesting and good signals that we're probably in the right track, because we found some symptom correlations, which you weren't seeing with gastric emptying test, for example. This is a great study by a colleague of mine in Garaband's, who showed that in patients with both functional dyspepsia and gastroparesis, the wave directions would be abnormal. They should be going towards the pylorus as the stomach does its antegrade motility. But we found that a lot of these waves are traveling backwards or become irregular. And these percentage of slow waves with abnormal propagation had a correlation with the mean GCSI symptom score in these patients, indicating that this was probably pathophysiological. If you're getting symptom correlations, you know you're kind of on the right track for pathophysiology. So this led us to get excited, and we built a medical device to do this make it widely available to clinicians, and to really discover what was going on with this part of these disorders and these gastric symptoms. And we called the device gastricolimetry. I'm very pleased to say it's now got UK clearance through MHRA, and it'll be coming, I think, first to the functional gut clinic in October. So we're very excited about it launching in the UK soon. So the technology itself is it consists of a flexible electrode. It's kind of like a large electrode pad, an ECG for the stomach, and this wearable reader device. And we've got an app that allows the patient to log their symptoms. And that's really important. So I'll show you in a minute. And then at the end of the test, all the data goes up to a cloud, and the clinician's simply able to log in and get the report directly after the test is completed. I'll show you a video quickly for how this works, what it looks like. So this is what the array looks like on the patient. It covers quite a large area, which is important because the stomach is variable in its position, and they can get up and walk around during the test because it's completely wireless. We conduct it pretty similar to a gastric emptying test. They arrive fasted. It takes about 5 minutes to set up with this flexible pad. It's prepped and it's placed on. Then the patient sits in a chair and they log their symptoms into the app. And these symptoms are pain, nausea, bloating, stomach burn, excessive fullness, early satiety. And if they vomit or reflux, they can do it. We give them a meal to stimulate the stomach. That's just an off-the-shelf meal. And then they continue logging their symptoms for 4 hours after the test, which is, again, similar to a gastric emptying test. So it's all pretty comfortable for the patients. They like it because there's no tubes, and it's a pretty comfortable procedure to undergo. This is the app showing how it works. They log their symptoms in this interface, and we've validated the app to be a validated patient-reported outcome tool against PAGI-SIM and PAGI-QOL to show that it's valid. At the end of the test, a report is given back to the clinician, and this includes 3 different parts. It includes the physiology on the front page, the symptoms on the second page, and then some technical data on the quality of test in the 3rd page. And then we've got the signals as well, if you wanted to drill down and look at the actual signals. And I'll just briefly show you some examples of where this is heading so that you can see why we're excited about this contributing. The last thing it can do are these spatial analyses, so we can see these wave directions. This is still a work in progress to validate it clinically, but it's a really interesting research tool that's coming through that will give us more information about some of these patients having retrograde waves in their stomach. And we're still discovering the full meaning of that. It's a very interesting finding. So these are some of the key biomarkers, a little bit similar to a high resolution EGG. So it gives us a frequency, a rhythm, an amplitude. It can be low in myopathic disorders or high when there's an obstruction. And the meal response, we want to see after the meal, often there should be a strong meal response kick in when the stomach starts contracting. And we've done a reference range study of 110 patients that we've just got submitted at the moment. that put some numbers on these so they're easy to interpret. So just some examples here. When the stomach's doing its normal thing with antegrade waves, as we saw invasively, you'll get a nice clean line on the body surface map showing a regular 3 cycle per minute test, similar to the EGG there. And when things become irregular with these neuromuscular disorders, where we've got the cellular pathologies, we get a very irregular looking body surface projection, and will start to look like this. So it allows us to start subgrouping these patients into those that have normal functioning neuromuscular stomachs and those with neuromuscular pathologies. There are some other pathologies that we're trying to classify to bring these patients down into subgroups or specific phenotypes. And one that we're very interested in is a number with these really high amplitude and really clean traces. And this is what Anthony was talking about when the stomach, we think these relate to a tight valve or a gastric outlet problem, where you can, the stomach starts to compensate by contracting harder. You can see in the symptoms here, this patient with gastroparesis, a lot of them starting after the meal. Nausea, bloating, pain, heartburn. We really like the symptom correlations, and the clinicians feedback to us that this is one of the most useful things about the test, because they can see whether the patient's symptoms are actually responding to a meal and responding to the stomach or not. Here's an example of a transient abnormality that occurred after a meal and a patient with functional dyspepsia getting bloating and excessive fullness while the stomach is irregular. This little transient dip here in its frequency. Frequency on the y-axis and the amplitude is the color. So you see here after the meal, it was nice and regular, then the frequency dipped, became very irregular, and then stabilized, and that's when they had their symptoms. This is an example of a neuromuscular patient with idiopathic gastroparesis and getting nausea and pain after a meal that just stays constant for 4 hours. Compare that to this patient with, this is actually a pretty normal test. It's a normal rate and rhythm, but their symptoms are completely continuous. They don't respond to the meal. They don't seem to relate to the stomach at all. So these ones we tend to think more have a centrally mediated pain syndrome, or it can be driven by vagal neuropathy, where their symptoms are just constant. It doesn't seem to relate to the stomach neuromuscular function at all. In some patients, we get a surprise and we find that their symptoms actually look delayed after the stomach is finished. So you see here the meal, and then the stomach activity kicks in, and then the stomach's gone quiet again, it's finished. And then the symptoms are really starting to ramp up with bloating and stomach burn and things. And these we think are coming probably from the small bowel rather than the stomach. So the symptom correlation together with the test is a pretty important part of it. Just going to finish by talking about a study that we've just had accepted in Science Translational Medicine coming out in gastroparetic patients. And we're pretty excited about really starting to break these big labels down into specific phenotypes of disease. So these were 43 patients, and we got 43 matched controls, and half of them had delayed gastric emptying and half of them didn't, but all of them had the same types of symptoms. And again, getting to that point that gastric emptying here is not everything and doesn't capture the full spectrum of this disease. The really interesting finding was that 60% of them in this study had completely normal stomachs on our test. And 40% of them had really abnormal stomachs. So we think this is the group with the neuromuscular problems, with these interstitial cells of Kahala damaged, and their stomachs are making very irregular patterns. And we could really separate these two groups out with this test. And this also matches about the frequency that people see when they do biopsies in these patients. But the interesting thing is their symptoms were the same. They were indistinguishable between the groups. What was really interesting was that the ones with normal stomachs had much higher rates of anxiety and depression, and much more likely to be on anxiety and depression medications, much more likely to have higher anxiety scores on the day of the test as well. Whereas the ones who had abnormal stomachs tended not to have those. Very few of them had anxiety and depression. And so perhaps as well, these ones with normal stomachs are showing more gut-brain pathology than the ones with the abnormal stomachs, where it's more neuromuscular. The final slide here just shows those symptom correlations. Again, one of the exciting things about this test is that we're seeing symptom correlations that we weren't seeing with delayed gastric emptying testing. So on the left, we have all the patients with the normal tests, and these are a range of features that correlate with symptoms in purple. And in the ones with the normal tests, we had the depression and anxiety scores that's correlated really strongly with their symptoms. And the ones with the abnormal tests in this study, and we found that anxiety and depression didn't correlate with their symptoms, but our test metrics, the stability of the waves, the frequency and the rhythm and stability did correlate strongly with the symptoms. So again, it kind of makes us feel like we're on the right track with trying to subgroup these disorders. So what's the future? I really hope the field can start to move beyond gastric emptying and symptoms. They will remain important, obviously, and important guides to treatment, but I think there's more to the story. And that story is going to come through specific physiological tests that correlate with symptoms. And that's what we hope we're providing one part of. And others, EndoFlip and others may provide another part of that. But we hope that we're really defining these neuromuscular problems with the stomach pump. And ultimately, you know, we hope gastroparesis will become a type 1 problem where we can put specific treatments on specific phenotypes and work out the place of important treatments like GPOM and others. So thank you very much, and really appreciated being part of the webinar, Anthony.
Thanks, Greg. That was fantastic. You know, it really does give us an insight into the future and where we're heading. I've got a couple of just little points that I want to make. You know, I think when people are talking about big interventions like a GPOM and not really knowing, you know, which patients to operate on, you know, I think you showed there that, you know, 60% of people actually have a normal stomach. And the last thing you really want to do is an intervention that then, you know, is a permanent, you know, cut through a muscle. And, you know, I think that's going to be really important. So in those patients, how do you kind of then break it to them that, hey guys, great news, your stomach is normal, this is the pathway you've got to go down? What kind of support do you give those patients?
Yeah, good question. So some of them, I should say, in that study when we did it, we didn't have our reference range. And since then we've looked back and a few of them fell out of the reference range. So they had really high amplitude activity. And we still think those ones probably might benefit from a GPOM, for example, where they've got really hyperactive stomachs, but a lot of them are normal. And in those ones, it is a communication thing with the patients. But the first thing often is to reassure them that we've done this test and your stomach is actually functioning well, and they're still experiencing symptoms. You have to validate that. It's really important. But often it can be really helpful for them. We've had a few patients on really invasive therapies, even parenteral nutrition here, and we've done tests and found that their stomachs are normal. And sometimes that just gives you the confidence to go back to the patient and say, your stomach actually appears to be functioning normally. This is a sensory disorder with your stomach. And it's allowed us to wean, you know, several patients off invasive nutritional therapies, just giving that confidence to then wrap other layers of support around them with some psychological help, some dietitian help, and work out how to get them back on a path to eating. So overall, it's good. It's just how you communicate it, I think, you know, to get that sensory message across.
Yeah, we saw a patient like this today, and we were talking to the consultant who this patient was on parental nutrition, and the cost of that per year is somewhere between £40,000 and £50,000 a year. So, you know, you can see that if you can actually not only get patients and support them and select the right ones, that not only will it be great and beneficial to the patients, but the, you know, saving to healthcare resources would be fairly huge. In terms of the studies that you're doing with pyloric outflow, have you seen any good positive predictive factors for how people are benefiting from pyloric intervention after the diagnosis?
Yeah, we've only really got sort of anecdotal level case series at the moment with it. We don't do a lot of GPOMs in New Zealand, and we're starting to work with overseas centres, including hopefully some in the UK, to really answer this question properly at a level. But we have seen definite changes in our test after a GPOM. The duration that the activity goes for will be less, as the stomach's obviously emptying faster. The amplitude can come down, and we've seen symptom drops associated with that. But really, at the moment, it's kind of case series level, so it's exploratory rather than definitive.
Have any other of my panelists got any questions?
Yeah, I've got a question, Greg. So in patients with an accommodation issue who can't or perhaps won't eat the test meal, would you still do the recording, you know, just depending on how much they've eaten, or would you change to something else? Is that, you know, their preference?
Yeah, so if they eat 50% of it, we still get a reliable test, is what we've found. And the high majority can eat 50% of the meal. It's just an off-the-shelf bar and a drink. I think a couple can't, and we still get results. So Occasionally a patient won't eat anything, and then you just give them some water and get a suboptimal test. But the majority of times you can. We don't measure the whole function of the stomach. It's important to say that. So accommodation, for example, we don't measure that. So that's where a combination of tests is still important for these patients, and this will find a role in the armamentarium, but won't answer all patients' questions.
I've got one more question about the subpopulation where they get delayed symptoms. Do you think this, because in one of your slides you talked about dysbiosis, do you think these are patients who may have things like bacterial overgrowth or carbohydrate malabsorption that might be contributing to their symptoms?
Absolutely, that's what we definitely think, that these patients should go on to have hydrogen breath test or something like a placebo, so that, especially the ones with bloating, definitely. Some of them also have the stomach burn phenomenon, where that's more what I think the functional dyspepsia guys are really looking at with other types of dysbiosis. But I do think it's necessary to then go down a small bowel testing route.
Okay, so well, that brings us to a close. I think that was a really enjoyable event, and the recordings will be made available both in individual talks and as a group talk for people to see. So those people who couldn't join live will be able to, and then we'll release it more widely after the event as well. So it just leaves me to thank Noor and Greg for joining us at various different ends of the temporal spectrum, and for Jordan for organising this. I hope everyone's enjoyed it, and I look forward to getting feedback and to our next webinar in a couple of months. Thank you very much, everyone. Have a good evening.
Thank you.
Thanks, everyone. Great to be here.